let's talk about this. 42-year-old woman has severe smoke inhalation from a house fire. She's in the emergency department, and the patient complains of a severe headache, has cherry red discoloration of her skin and mucous membranes. Which of the following lab findings is most likely? So choices are decreased arterial O2 sat, a decreased P-little-a-O2, increased alveolar arterial gradient, increased serum bicarbonate, and a normal total O2 content. So what do you think, everyone? What do you think is going to be the right answer here? So let's go back to the vignette. So I know I did a couple cliche things in here. So someone comes in with a house fire, who unfortunately had a house fire, severe smoke inhalation, buzzworst, cherry red discoloration of the skin. What are we worried about in this case? Yeah, I mean, you folks are amazing. This is possibly someone who has carbon monoxide toxicity. And on your board exams, this is something that they love to ask, especially if you want to integrate it with, hey, do you understand some of the basic science behind it? And why do they put this here? Especially for people like me that are researching, they really want to make sure that you know some of the pulmonary physiology. So let's go through this together. Well, number one, which ones would I cross off right off the bat? So in CO2, carbon monoxide, toxicity, I would cross out D. Would serum bicarbonate be elevated in carbon monoxide toxicity? The answer is probably not. If anything, you could probably convince me it would probably be low. Maybe the patient could develop a lactic acidosis for a variety of reasons. But to have an elevated serum bicarb, to be alkalotic, it really doesn't fit the pattern of carbon monoxide toxicity. All right. What about C, the A gradient? I know we spoke a little bit about that in the previous question. The big A is going to be the alveolar oxygen. That oxygen is going to diffuse through the alveoli, through the interstitium, and end up in the pulmonary capillaries. So if you have carbon monoxide toxicity, is that going to make the A gradient widened? Would it be increased? The answer is probably not, right? So I think C is going to be, the wrong answer. The A gradient should be pretty much, should be normal in these cases. Okay. What about the P-little-a-O2, the dissolved oxygen, if you have carbon monoxide toxicity? Would it go down? The answer is probably not. And this goes back to, well, what really influences the value of the P-little-a-O2? And I really could think of three main things. What three things influence the dissolved oxygen? Number one is going to be atmospheric pressure. And of course, if you go to Mount Kilimanjaro, the PO2 is going to be what? Low. We just talked about that. Number two is going to be the FiO2. So if I give you more, fractional percent of oxygen, what happens to the PaO2? It's going to go up. And the last thing is minute ventilation. So if you're going to be hyperventilating, of course, the PaO2 is going to go up. If you're hypoventilating, the PO2 is going to go up, down. So this is carbon monoxide. It really shouldn't affect that. It really comes down to, is the answer going to be A or E? And the way I look at it, folks, I don't know if anyone's got an answer already. Just raise your hand. I know I can't see. But, if you have carbon monoxide, remember, it loves to bind to hemoglobin. It does. And when it binds to hemoglobin, it steals one of those binding spots for oxygen. So what happens is that if you are talking about total oxygen content, it's made up of two measurable things. That's going to be the O2 sat, amount of oxygen bound to hemoglobin, and the dissolved oxygen. So if the O2 sat is going down because carbon monoxide is stealing one of those binding spots, well, the total oxygen content can't be normal. It's got to be what? Low. So what is the right answer over here is? The answer has to be A, a decreased oxygen saturation. But wait, I'm sure someone's saying when you have carbon monoxide toxicity, why is the O2 sat, when you do a pulse oximeter, why is it going to be 100%? And the answer is, it's because that's a pulse oximeter. It measures one wave of hemoglobin, which is going to be what? Oxyhemoglobin. So when we talk about, checking that carboxyhemoglobin level, How do you do it on the boards? How do you do it in your hospital? Yeah, you got to find that artery and get a what? ABG. And from that ABG, you have to find a co-oximeter, and here's a little picture of a co-oximeter over here. And you have to run it through there to kind of get that carboxyhemoglobin level. And of course, when we talk about carbon monoxide toxicity, if they ask me just one-dimensionally, how do you treat it? Of course, oxygen first. In severe cases, when we talk about arrhythmias in the heart, and when we talk about mental status changes and seizures, yes, if available, you could consider, a hyperbaric chamber. That's, sometimes not easy to come by. But of course, giving supplemental oxygen in these cases. So I thought this was a great question to talk about when we talk about total oxygen content. And I just put this in here because somehow manages to make its way on every pulmonary board exam, which is what we've called the oxygen dissociation curve. And what did I put this here for? One reason for all my pulmonologists out there who know this, on the y-axis, you have O2 saturation. On the x-axis, you have the P(a)O2, dissolved oxygen. And why is this very important when we're training our fellows to talk about the steep and the flat parts of the curve? So remember, when you're on the flat part of the curve, that's going to be when you intubate someone like me. That next thing you know, you push the induction drugs, and you're going to have, a good buffer of time to find those vocal cords and put the tube in. Because, as my P(a)O2 is dropping and dropping and dropping, it really goes all the way down to 60 before really I notice a big change in my O2 sat. But if you're going to be on the steep part of the curve, and I'm sure all of us experiences this during the COVID-19 pandemic, patients come in so hypoxic and God forbid they need to go on the ventilator. The minute you induce them, you push the induction drugs, you push the etomidate, you push the paralytic, what happens to their O2 sat? Well, it drops very quickly because they're on that steep part of the curve. Also, still, they may even ask you what happens when you shift the curve to the right or left. If you shift the curve to the right, of course, you're giving off that oxygen easily to the tissues. One of my favorite mnemonics is TAP, T for temperature. When you're going to be, febrile, shift the curve to the right. If you're going to be acidotic, pH is going to be low, shift the curve to the right. And of course, something we don't see in the pulmonary boards that much, high levels of 2,3 DPG or BPG, shifting the curve to the right. We see those high levels in patients who are going to be hypoxic. And of course, when you want to shift the curve to the left, there are very unique ways to do that. One of those ways is going to be carbon monoxide, which was just the question that we talked about before this. Now, if I were to ask you folks who are listening, beyond shifting the curve to the right, shifting the curve to the left, can the curve be shifted up and down? What do you folks think? And the answer is, yeah, it can. So who can tell me, how do you shift the curve up? You folks are so amazing. That's right. When you're going to be what? Polycythemic. So when you increase the amount of taxicabs, you increase the amount of hemoglobin, well, of course, you're shifting the curve up. When we talk about shifting the curve down, it'll be the opposite. It's going to be anemia of any cause, whether it's a microcytic anemia or a macrocytic anemia, it really doesn't matter. So I put this here so you can always review this on your own. I think it's very important, even at the level of the pulmonary boards, to understand, what influences your PaO2, your hemoglobin concentration, and the amount of hemoglobin that's going to be attached, the amount of oxygen, attached to the hemoglobin, because these three things make up total oxygen content. And what I wanted to show was going to be, when we had the previous question, it was about carbon monoxide toxicity. And the answer was total oxygen content should be low. It shouldn't be normal. And some of you said, why? Because in carbon monoxide, poisoning, P(a)O2 should be normal because it's not atmospheric pressure. You're not changing FaO2. You're not increasing or decreasing your minute ventilation. Your hemoglobin concentration will not be affected when you have acute carbon monoxide poisoning. But what's going to change is the amount of oxygen bound to the hemoglobin, because carbon monoxide is going to be bound strong to one of those binding spots. So if one of these three go down, then total oxygen content needs to be low. And that's why total oxygen content was going to be low in that specific case. Wonderful.